what I try to say here is that we'll do it like a case study, and that whenever we see a diabetes subject, say a person who walks into your clinic with a random 250 sugar, fasting, 300 sugar, PP, A1C of around 10, he's just not bothered. He just went for a health checkup and he got to find out that these are his numbers, and then the doctor perhaps, with folded hands, and finally we get to know who this man is. Where is he standing? What is his problem? His problem is not diabetes. Diabetes is just not few numbers. Diabetes is top to toe. So where does he stand? We really don't do this. That's the problem. We just treat those numbers. So this is one slide deck which I started making while I was making this. I thought that I would include these old slides, but quite meaningful, I believe. At least this is old data. This is what we see in actually developing country. We also fall under developing country, and these are the data. If you are a diabetes at the moment, a diabetes subject, then there's chance that you have almost 50%. You have a macrovascular disease with it. And that's exactly what Wikipedia has showed us, that more than 50% of the new onset diabetes subjects, they had macrovascular disease. You already can have a history of stroke, 10%, 14%, 15% can have MI when you present to the doctor's clinic. Now, this is my country. A quarter of all mortality is attributable to CVD. Premature mortality in terms of years of life lost because of CVD in India increased by 59% from 23.2 million to 37 million. That was a difference of just about 20 years, 59% increase. Almost 80% of the CVD deaths are due to ischemic heart disease and stroke. And this man, finally, he falls, and he falls where the global average of the global burden of disease, the estimated age standardized CVD death globally is 235. India has 272. Now, this is the man I was talking about, 42 years old man. Father had MI and perhaps died. Yes, he died at 56. These were his symptoms when he came to me. This is his anthropometry, and these are his numbers. So what would I do next to the patient? 42, young, bubbly. Father died at 56. What is my target? The house, the target. Don't get dissuaded by, rather effaced by those ACP guidelines, old man Bloomgarten's guidelines. Let's talk science, let's talk sense in our country. Our guideline, A1C, 6.5, bang on, that's right. So, why? Because we need to now know that these are the changes that keep happening just with 1% decrement of A1C. They paint a powerful picture. And now if you reduce the A1C from 10 to 8 or 9 to 7, then perhaps they double also. That's the data. And how you treat a patient now, patient-centric management, ADA-ESD guidelines. This is the guideline. That the duration is 2 years and more, life expectancy is huge, relevant comorbidities, just microalbumin, showing up, established vascular disease, no, we don't know as yet, didn't put him on TMT. Patient attitude, he forgets his medicines once in a while, but he has all the good wish to live. And resource and support of IT chap, perhaps he has good resources readily. So he comes under that 6.5 bracket. So our target is 6.5. Now, this is the only risk assessment that I found when we talk about Indians. So there you can put in the ethnicity of Indian. Other the Q-risk, ASCVD, Framingham, we don't have Indians. So I thought it was justified to put this New Zealand parameters, where this guy has a 15.6% 5-year cardiovascular disease risk, right? And then what I did, I thought that let's 42 become 52. Just enhance the age, but keep his sugar under control. Only the age. What is the prognosis? 10 years down the line, the risk is now going up from 15, it has gone up to 22, despite the good control. Now these are the data. Death in people due to diabetes, 40% due to IHD, 15% due to congestive heart failure, 10% due to stroke. Death. CVD events happening in diabetes. CAD obviously around more than 4-fold, stroke around 3-fold, and if the patient is young, then unfortunately less than 44. This is Lau Wang's paper. It is almost 10 times. Now what's special about heart failure? In type 2 diabetes, 2/3 of the deaths, can I have a monitor here please? 2/3 of the deaths are related to CV disease, partly driven by CAD hypertensive cardiomyopathy. Heart failure is particularly frequent in patients with type 2 with a 2.5-fold higher incidence than without diabetes. Myocardial infarction numbers, though they have reduced 25% in the past 10 years, yet surprisingly the heart failure rates are going up. Ischemic heart disease and hypertension are frequently associated with heart failure in 65% and 75% of the type 2 patients respectively. Heart failure outcomes remain poor with a 5-year survival of about 50%, leading to poor prognosis than with most cancers. Heart failure incidence double in patients with diabetes for every decade over the age of 45. Now these are data that we should remember. Age was the strongest predictor for developing heart failure with 40% increased risk for every 5-year increment in age in the older persons. Several large cohort studies said that even when you look at a heart failure patient, you're examining a heart failure case, perhaps 50% of them will have diabetes. Now these are the death threats. Life expectancy is reduced by 6 years if you have diabetes, and if you have diabetes plus an evidence of MI past, then 12 years. This is the ticking clock hypothesis that diabetes and heart disease, they are kind of common soil hypothesis. So they are going in line together. And therefore, this is a paper which said that you have, before diabetes, almost 3 times relative risk of having heart attack. This is the pathogenesis of how it all happens. Diabetes happens. And if diabetes happens, you have these as the problem, and therefore, these are the fallout. You have advanced glycated end product production, less of nitric oxide, more of PKC, more of platelet and coagulation system activation, and less of PPAR activation. Finally, you have CVD. This is the continuum. This is the risk associated with delaying insulin, increased complications. So these are the complications setting in those subjects with so much of duration of diabetes but no insulin given. This is what happens, what are the benefits, where you actually early insulin rise. See, you go into remission, patients achieve euglycemia. So many patients, right? And they are into remission for 6 years, 6 months, 1 year. And it continues. So what you do actually is effectively the man is on fire. This 42-year-old guy, 10.2 A1C, he's on fire. So you have to douse the fire. The glucolipotoxicity has to go down. And what's the best agent to douse a fire? Suppose there's a fire in this room. What will we do? We will search for water. And the best molecule, which looks like water, in the armamentarium is obviously insulin. Because the other molecules are chemicals, and you can douse the fire. You can put a pillow, but when the fire douses, but there's scar of the cotton all scattered around. So this is how it all happens. Beta cell is given rest. There's reduced strain, reduced toxicity, sustained insulin. In that kind of fire, the beta cells were actually hiding in hibernation, because beta cells are like a baby of beautiful girls, and alpha cells are like angry, alpha cells are angry young men who protect the beautiful girls. That's if you look at the pancreas. So that is when there's too much of fire, beta cells don't work. But immediately once you get the sugar under control, they start secreting gradually the endogenous secretion. And also the peripheral uptake, etc., improves. So now in this case, what will you give? You've already given him glimepiride. He's having minus 5 milligram BD, metformin 1000 BD. So, and he's losing weight. he's cachectic, he has catabolic features. What is our target? 6.5. So what will we give? He's losing weight. Mind you, he's losing weight, he's losing time as well. Because time is heart, time is cardiomyocyte. Now, the agents when they're added to metformin, these are the changes in A1C that we know of. AAC statement, insulin is the most potent anti-hyperglycemic agent spanning across the continuum, always efficacious. Patients taking 2 OADs who have A1C more than 8 and a long-standing diabetes are less likely to reach their target with another third OAD. Although adding a GLP-1 agonist as a third agent may successfully lower glycemia, eventually patients will require insulin. When insulin becomes necessary, a single daily dose of basal insulin can be added or should be added to the regimen to start with. This is that Lebowitz's paper. He had that, type 2, phase 1, phase 2, phase 3. I just quoted that 1999 paper. Insulin therapy, he said, let's have a rescue therapy. Like he's on fire now. Let's rescue him at the beginning, at the diagnosis. 250 fasting, PP 300, A1C 10, put him on insulin, rescue therapy. He is now continuing glibenclamide 5-BD, metformin 5-BD, but things are not improving, augmentation therapy. And finally, as the natural progressive course timeline of diabetes, he will run dry of, because the glibenclamide will flog the beta cells, they will be tired and they will be dead horses, and you need the horses to be pulled up in a cart and then dragged along, and that cart will be replacement insulin therapy. So rescue therapy, augmentation therapy, replacement therapy. Now, I'll come to this AKT and cardiomyocyte. So this is a complex slide, but as we all know, the insulin receptor, if you talk about it's a beta cell or a cardiomyocyte, whatever, then insulin receptor, insulin will come, sit on the insulin receptor. There is also the IGF-1 sitting side by side, that gets activated as well. It triggers the AKT, and the AKT has is it not legible? Not readable? Anyway, so what happens is, there's a cascade of events. And mind you, each AKT makes its own destiny. And I'll just briefly tell you what happens, is that AKT at the crossroads of insulin and insulin-like growth factor, IGF-1, they activate signal transduction pathways. All these signal transduction, whether in the nucleus or the sarcoplasmic reticulum or the mitochondria of the cardiomyocyte, they have their own actions. And binding of insulin or IGF-1 activates PI3K and generates inositol lipids that bind to the plexin domain of the AKT, and which is therefore located to the plasma membrane, becomes a substrate for the PDK. Once activated, AKT migrates on plasma membrane itself, cytoplasm, mitochondria, nucleus, phosphorylating the key effector molecules. Now, the key effector molecules are both ways. One is the PI3K pathway, the AKT, the other is the MAPK pathway. And the result of the multitude of the effects is improvement of metabolism, inotropies, and survival. And then the next slide is the slide which talks about the impact of degludec or glargine or the long-acting insulin, how they are actually taking care of the affinity, the binding for the AKT, whether it's serine 473. See, the highest is insulin glargine. So therefore, AKT binding is happening with glargine the best. This is the effect that happens with, you have high blood sugar, you are diabetic, you are toxic diabetic. What happens is ROS, the NADH, that pentose pathway, right? And the PI3K now is activated, overactivated. That triggers the AKT, overactivated. That has a signal cascade to give this. This is a high mobility. This is called a high mobility group box 1. This is actually very important in the body. But if it is expressed in higher numbers, then it can cause detrimental effect. Like it can cause cardiac fibroblast activities. It will cause apoptosis, hypertrophy in the cardiomyocytes, cardiac stem cell proliferation and differentiation. But if it is given in the normal position, in the normal quantum, the physiological quantum, then it improves cardiac function. This is again the insulin signaling pathway happening in the cardiomyocyte. This is how IGF and oxidative stress is there in a diabetes subject, but the impact of IGF, activated IGF, which is the optimally done by glargine, papers are saying, they will inhibit the oxidative stress that is happening within the cardiomyocyte, finally preventing atherosclerosis. This is the similar pathway saying it's blown up, and this is insulin, activates on the insulin receptor substrate 1 and the MAPK, the mitogen activated phosphokinase. There, that pathway gives rise to vasoconstriction. This pathway, PI3K-AKT, gives rise to the endothelial nitric oxide synthase. That increases vascular tone, that diminishes the vascular smooth muscle proliferation, that diminishes the platelet aggregation to the endothelium, that diminishes the ROS production, and that also diminishes the adhesion of the inflammatory cells, the monocyte, the MCP, etc., all the selectin, all the other chemokines. But what happens is, if you are in a hyperinsulinemic state, if you're like an Indian state, then this hyperinsulinemia, what it does, it shuts down this pathway and starts activating this pathway. And therefore, a hyperinsulinemia and cardiovascular disease go hand in hand. Common soil hypothesis. This is the study with insulin glargine is reducing carotid intimal hyperplasia even after balloon catheter surgery. So these are the, see, this is after glargine, this was after glulicin. This is carotid artery response with glargine. Intima media thickness is less. And this is the insulin and the metabolite of glargine. The insulin and the metabolite of glargine, this is very less here. So those fat words which used to go buzzing around about glargine causing mitotoxicity, mitogenicity, they don't stand chance now, because IGF as a molecule, if it is not a receptor, is not harmed or deranged, glargine per se cannot cause malignancy. So these are the papers for it. I just kind of rummaged through all the data that I could manage, and I put up all these slides. These are the outcomes of insulin glargine, and this is quite important, that we understood the benefit of early insulinization long back. But origin came into our minds when it was given to even pre-diabetes subjects, and at a long trial, 6 years trial, and which said that when used to target normal fasting plasma glucose for more than 6 years, insulin glargine had a neutral effect on cardiovascular outcomes and cancer. And then came origin grace, right, which said that in patients with CV disease, already established CV disease, CV risk factors was all the subjects with origin, insulin glargine modestly reduced CIMT progression. And originally, during more than 6 years of treatment, followed by 2.5 years of observation, insulin glargine kept on having neutral effect on health outcomes like CV events and cancer. So these are the effects of insulin. This, we know that the glycemic memory, the good glycemic memory, good glycemic legacy, that this is actually the real course, how it happens. Ideal course is if we can bring down the A1C and keep it like that constant, but we can't. We give one OAD, it comes down, it shoots up, give another OAD or titrate or optimize the dose of that OAD, give another OAD, 3 OADs, finally with a lot of lethargy, which is clinical inertia. And I say, we talk about patient psychological insulin resistance. The worst in this country, or perhaps more or less everywhere, is the physician's insulin resistance. India is a country of insulin resistance, more so because we as physicians are more insulin resistant. So if we can, bridge that gap, things would look better. When to prioritize basal insulin? When hyperglycemia is severe, symptoms of hyperglycemia is there, when there are catabolic features, basal insulin has the advantage of effectively lowering blood glucose when other medications perhaps may not. These are the 2019 data. How to initiate, we'll not go into that. We need to have educate a team, we need to have an integrated team approach, and insulinization can work like a magic in 3 to 7 days. Patient is empowered, provider is happy, and the whole team is getting results. So these are the targets, and of course involve the team. So back to patient action plan. This is the guy. We want to reinforce that his A1C target is 6.5, his fasting is around less than 110, and prescribe a high potency statin for his elevated lipids, establish check-in schedule to report his SMBG. This is very important, the crux, the AAD 7 points. You have to eat well, you have to exercise, medicines. Then the other M is monitoring, and that's the most important. I mean, if you don't care to share one drop of happy-looking blood with, for your happiness, you are not getting the results. And then you have problem coping, your risk reduction, etc. So this is the patient recap, that the patient is there, and patient needs to get in touch with the team, sets up consult with the educator, nutritionist to support adherence and address the lifestyle changes. And you also have to send him to the quit smoking cessation clinic as well. Now, having said that, this is the last slide that I'll talk about, that the global insulin use for type 2 diabetes 2018 and 30, this microsimulation analysis said that actually with this, you can take care of the disability adjusted life years. The dailies can come under control. And insulin required to treat type 2 diabetes is expected to increase by more than 20% from 2018 to 2030. More dailies might be averted if A1C targets are a little higher than we now recommend for older adults. So I think, is my time up, or whatever it is? I mean, the thing is, if I'm allowed to say, glargine, we have not come here to talk big words about glargine. Glargine and all the other basal insulins basically will act accordingly. But one slide made the difference where I showed categorically that glargine is doing well. Glargine per se is doing well compared to degludec. Now, having said that, in this kind of a setting, if you're trying to protect a person from having his complications early, the best method is to get his overall control at the earliest. And if you can put him under the spell, the magical spell of insulin, then you'll realize that the man is worth living a life that you've been thinking about him, because he has no clue. As a diabetic subject, he has no clue. So you have to empower him, you have to teach him the richness, the goodness of the product called insulin, and that there's nothing as sacrosanct as that. And all those vibes and those stray remarks about insulin causing cancer, etc., are not validated at all. The only problem is our problem, that as physicians, we are afraid that at 3 o'clock I'll get a call, patient is hypoglycemic, he'll wake me up. They will call me up for adjusting the dose. Look, there's no starting dose. No starting dose can be right or wrong. There is a standard dictum, 0.5 to all those 0.1 to 0.2 basal. Then if you want to give premix, what I do is 0.3 into the per kg body weight, 70 kg, so 21 units to start with. So I give 2/3 in the morning and 1/3 at night, so 14 and 7. And you start and keep checking. Keep checking fasting, keep checking the PP ones. The PPs can be done at 90 minutes, not 120 minutes in our country. And we have seen this repeatedly. We have done more than 10,000 CGMS, and we found that in our kind of diet, the peak postprandial is around 90 minutes. So as ADA rightly says, that ADA says that 180 is the target peak prandial. But we will say that we'll stick to AAC and IDF for that, say that peak postprandial should be 140. So these are the things that the educator should know. Talk to the patients regularly at length, and then is it just a cakewalk? And once the patient is, the best part, once the patient is adjusted himself well to insulin, he will never ever come to you and say, भाई कितना दिन लेना पड़ेगा इंसुलिन मानो तो लाइफ लॉन्ग. तो हम बोलेंगे अब तो दंतमंजन करते हो सुबह से बचपन से, वो क्या लाइफ लॉन्ग नहीं, बंद कर दिया, पानी पीते हो बंद कर दिया, तो इंसुलिन क्या हम किया आपको? तो तब वो कभी नहीं बोलेगा आपका पास, आएगा ही नहीं. बोलो डॉक्टर साहब अभी बोले थे अब इंसुलिन देंगे, जल्दी दो. So this is a learning, and the team approach should be there. You have to have an educator in your system. And that's we are crying aloud. I was sharing with Anandada at the ADA conference that we have promulgated a concept called International Diabetes Educators Day. That is 5th of September, which is in our country Teachers Day. 2016 we promulgated. Fortunately, AAD has already approved that, and IDF has approved that, and now we will take it forward for our educator brothers and sisters in the country and around the world to drive it strongly so that the patients can feel better and remain well. Thank you.